Next speaker, Dr. Ellis is an assistant professor in the Department of Psychiatry at Washington University in St. Louis. He holds a master's degree in psychiatric epidemiology and a doctorate in public health. He has worked for nearly 20 years in addiction epidemiology, focusing on opioid use disorder, abuse liability of prescription medications, polysubstance use, and the intersection of comorbid conditions such as psychiatric diagnoses, chronic pain, and infectious disease. He is a member of the Scientific Advisory Group for the National Drug Early Warning System. He is also on the editorial board for the Drug and Alcohol Dependence Journal and serves as a principal investigator with the Researched Abuse, Diversion, and Addiction-Related Surveillance, or RADAR system. Over to you, Dr. Ellis.
Thank you, Kate. All right, good morning, everyone. I want to thank RMPDS for inviting me to speak today. I only have 15 minutes, so I'm going to go ahead and dive right in. Just conflicts of interest or disclosures. I am a PI for one arm of the Treatment Center program for RADARs. As noted, I'm on the SAG for the National Drug Early Warning System, and I have a NIDA grant looking at the non-medical use of gabapentin opioids, which will become relevant later on. So today's talk is focusing on older adults. So why are we focusing on older adults? Well, one, we know that they are a vulnerable population. We know that they are more likely to receive opioid prescriptions. They're more likely to engage in polypharmacy or using multiple medications, often to manage multiple health comorbidities. And because of that, they are at increased risk for adverse events. We've also seen recent increases in overdose mortality in older adults, particularly among specific race and ethnicities, Native Americans and Black populations in particular. But most importantly, this age group is growing at a faster rate than other age groups. We know thinking through a public health lens, we not only need to be better prepared to manage this influx of older adults that's going to weigh on our population and our health systems, but we also need to better understand this population, thinking through a surveillance lens. And what we know about older adults is that they're more likely to engage in polypharmacy, and thinking about substance use, we know that polysubstance use is the norm. It's not the outlier, it's the norm. And so what we wanted to do was understand polysubstance use in older adult populations. And to do so, we used data from two of the programs from RADARs, the Survey of Non-Medical Use of Prescription Drugs, the NMURX, which Dr. Dart just talked a lot about. Again, just a general population of adults in the United States. And then the Treatment Center program, which is a national survey of individuals entering treatment for opioid use disorder. There are lots of ways that we can classify older adults. When we were looking through the literature in preparation for this presentation, we found the most common to be 55 and older. And so that is sort of where our cutoff is when we talk about older adults in this presentation. Again, the NMURX, it's a repeated cross-sectional survey through a panel company, roughly 60,000 respondents per year. We make sure that's through all 50 states because we want to produce nationally representative estimates. The survey asks lots of questions, but importantly for us, we're looking at both medical use, so use of a prescription as directed, and then non-medical use, so either use without a prescription or with a prescription other than as directed. And for recency's sake, we looked at data from 2022 to 2024. We defined polysubstance use as past year use, either medical or non-medical, of two or more of the following drug classes. So opioids, stimulants, benzodiazepines, gabapentin, cannabis, and then we sort of lumped together all other illicit drugs. So just the general overall prevalence of polysubstance use in those 55 and older was roughly 13.1%. It's a little bit lower than the other age categories, which is not surprising, particularly when we think about illicit drugs or cannabis, that older adults are less likely to engage in those types of use behaviors. Just quick demographic differences for those using two or more drug classes or those using one or zero drug classes. Adults age 55 and older with what we're calling polysubstance use were more likely to report being female, being divorced, earning less money, report poor or fair health. And then looking at health conditions, they're more likely to have a past year hospital stay, have past year acute pain, depression, anxiety, But what I really want to zero in on is that really high rate of past year chronic pain. So roughly 70% of that group reported chronic pain in the past year, which sort of associates with what we look at in terms of the specific drugs that were used in this group. So prescription opioids was number one, which is not surprising with that high rate of chronic pain that opioids were going to factor into this. It's still fairly high, 62.3%. And then not too far beneath that is cannabis at 55%. And gabapentin is pretty much on par with cannabis. Benzodiazepines are still in the mix at 44%. And then to a far lesser extent, we have the stimulants and illicit drugs. So what we did was look at all of these different drug combinations that were used. And so I know this is a busy slide, but what you see are the top 15 drug combinations. And on the left-hand side, you see a number, and that is the estimated number of individuals in the US that are engaging in that drug combination. Now, I'm not going to go through all of these, but what you can see here is that there seems to be an interplay between opioids, gabapentin, benzodiazepines, and cannabis. Cannabis actually showed up the most in 9 different groupings, followed by opioids and then gabapentin. You can see halfway down, we do see cannabis and illicit drugs, but that's the only combination where we see illicit drugs pop up in the top 15. And then you see non-medical use of opioids, GABA, and benzo as well. But what I want to highlight here is that just because that top group, prescription opioids used medically and the medical use of gabapentin, even though that was the most popular combination, I think it's important to remember that the medical use still carries risks. We know that there are risks of combining gabapentin and opioids. We know there are risks in combining opioids and benzos, and we know there are risks in combining gabapentin and benzos. So while we do see non-medical use as well, I just want to keep in mind that medical use of opioids in combination with other substances continues to carry risks as well. In terms of the overall prevalence, I know this is just from 2022 to 2024, but we do see an increase in past year polysubstance use in adults 55 and over. I think after we looked at this presentation, we do want to go back further to see what those trend lines look like from a longer point of view, but we do see an increase in this polysubstance use. When we look at the trend lines for specific drugs, opioids, benzos, and stimulants, we don't really see that much of a difference. Those 3 drugs pretty much stay on par between 2022 and 2024. Where we do see increases is we see a pretty stark increase in cannabis use. And then we do see increases in the use of gabapentin as well as increases in the use of illicit drugs in this population. Now, when we break this out to just the group that is engaging in polysubstance use, we looked at the use medically and the use non-medically. In the medical use, we do see that decrease in the medical use of prescription opioids. Where we do see an increase is the use of gabapentin medically. Now, I want to compare that to the non-medical use, because as opposed to that decrease in the medical use of opioids, we see an increase in the non-medical use of prescription opioids, which Dr. Dart sort of alluded to in his earlier presentation. But in addition to the increase in the medical use of gabapentin, we also see an increase in the non-medical use of gabapentin as well. And then again, you see that very stark increase in cannabis use in those 55 and older engaging in polysubstance use, almost a 10-point increase in 3 years. And then we also see an increase in the illicit drug use as well in this population. Now, shifting gears over to the treatment center program, in its current iteration, this has been going on since 2008, and it involves roughly 80 methadone clinics or opioid treatment programs, and then 80 opioid use disorder treatment programs of a bunch of different various modalities. So again, we looked at this data from 2022 to 2025 from roughly 7,000 participants. And just to provide some context of this population, about 11% of our population is 55 or older. But as you can see, in just those 3 years, we've seen a rate change. So I talked about this aging population increasing in the United States. I think we're starting to see that shift in our treatment population as well. So 45 to 54 had the greatest increase, which is going to move into that 55 plus population soon. but followed quickly by those 55 and older also had a pretty high rate of increase as well. Looking at what that past month opioid use trends are, to no surprise, illicit opioids are still the dominant force right now. But prescription opioids are still playing a significant role in those entering treatment for opioid use disorder. And you can see those age-related trends where as age increases, you're more likely to engage in the non-medical use of prescription opioids, and you're less likely to engage in the use of illicit opioids. But for that 55 and older group, prescription opioids are used by at least half of them. So it's still playing a significant role. And I don't think we can take our eyes off prescription opioids just for illicit opioids. Looking at specific prescription opioids, we do see age-related increases specifically for hydrocodone, tramadol, and methadone. The only drug where we see sort of a reverse trend is buprenorphine, whereas age increases, that's the one drug where we see a decrease in likelihood of non-medical use. I think this is a really interesting graph of looking at illicit opioids. As age increases, we see the use of heroin increase, but we see the use of fentanyl decrease. And in fact, 55 and older is the only age group where heroin use is more common than fentanyl use. Now, some of this is sort of explained looking at these sort of racial differences. So if you are a white individual, as your age increases, you're more likely to use prescription opioids non-medically and less likely to use illicit opioids. But that trend reverses for Black populations, where as age increases, you are less likely to engage in prescription opioid use and more likely to engage in illicit opioid use. Again, polysubstance use is the norm. And so we see high rates of polysubstance use in our population. However, the only drugs where we see higher use in those 55 and older are gabapentin and then other prescription drugs. So the non-medical use of things like sleeping pills, muscle relaxants, or antidepressants. But there really wasn't any significant increase for those 55 and older for any other type of polysubstance use. So we really wanted to understand more about the relationship between polysubstance use and sort of comorbid conditions. And so similar to NMURX, we see that chronic pain exists at a much higher rate in those 55 and older. You see that linear increase. We did not see any difference in mental health. Where we saw this difference was for chronic pain. And so we asked this question of what drugs have you used to self-manage your chronic pain? And I think this is an interesting graph where we see for these drugs, 1, 2, 3, 4, 5, 6 drugs, we saw age-related trends. So heroin, marijuana, crack cocaine, gabapentin again, methamphetamine, and then benzodiazepines for 45 and older. We see those increases of drugs being used for the purpose of self-managing chronic pain. And when we talk about chronic pain, I think there's sometimes people wonder, well, are people really referencing chronic pain, or are they referencing their bodily pain as a result of withdrawals or feeling sick? But we asked that question earlier in the survey, and we do not see those same trends. When we ask about bodily pain related to withdrawals, we see sort of a similar trend in gabapentin and crack cocaine, but for the other drugs, whereas we go back to the chronic pain, very clear trends for these drugs in terms of self-managing chronic pain, but they don't necessarily exist when we talk about bodily pain from withdrawal. So that gives a little bit more confidence that this drug use, at least by the individual's perception, is being used to manage chronic pain conditions. So we know there's an interplay there. This also seems to factor in, and when we look at motivations for seeking treatment, the reason for seeking treatment that has to do with mental or physical health comorbidities or physical or mental health issues, that one is endorsed at a much higher rate for those 55 and older, which makes sense given that high rate of chronic pain. We also ask if they're prescribed gabapentin in OUD treatment. Gabapentin has popped up throughout this presentation, and so we asked, are you prescribed a medication during your treatment program? 40% of those 55 and older are prescribed gabapentin in their treatment. Now, I'm going to take a brief diatribe on gabapentin here because I think it's really important. Prescriptions for gabapentin have skyrocketed in the past 15 years. not just by themselves, but co-prescribed alongside opioids. It's estimated that the vast majority of those gabapentin prescriptions are off-label. A lot of times, clinicians perceive gabapentin as being a safer substitute for benzodiazepines and opioids, so they are prescribed a lot more frequently, particularly in substance use treatment. It is prescribed for a range of conditions like insomnia, chronic pain, anxiety, or just to mitigate withdrawal symptoms. However, one of the issues is that there's little to no evidence base for its use in substance use treatment, with the exception of alcohol use disorder. So despite the fact that it's commonly prescribed, again, in our sample, it's prescribed to 40% of those 55 and older, the evidence base for it is very scant. Alongside those increased prescriptions, we've seen increases in gabapentin being identified in overdoses and increases in non-medical use. Now, there hasn't been a lot of research in the substance use field in terms of the relationship between gabapentin and opioids, but there is a lot of research in the pain field that has identified that the co-use of gabapentin and opioids increases your risks for adverse events, particularly respiratory depression. So it is an area of research that definitely needs more focus. And then finally, we ask individuals, what drugs have you taken right before, right after, or at the same time as an opioid? And the only drug where we saw a significantly higher rate for those 55 and older was gabapentin. So nearly a third of the population of those 55 and older are co-using gabapentin and opioids at the same time. So just brief takeaways from this short presentation. We are seeing increases in past year polysubstance use among older adults, including the non-medical use of prescription opioids and gabapentin and cannabis. In both samples, prescription opioids continue to play a significant role. Gabapentin use is notable and increasing, and there are significant associations with chronic pain. In terms of thinking of continued surveillance, we know that there's an interplay between benzos, GABA, opioids, and interestingly, cannabis. So I think when we talk about surveillance, we need to think about it through a more holistic lens. I know polysubstance use is a very popular topic, but we also need to understand what polysubstance use means and maybe find ways to better define it. In particular, of more direct ways of understanding use. Is it use on different days? Is it use on the same day? Is it use at the same day with overlapping effects? Or is it use at the exact same time? So I think those are things that we need to consider in the future of drug surveillance. So with that, I just want to acknowledge all the people who helped with this presentation, and that is my time. Thank you very much. I welcome any questions.
Thank you, Dr. Ellis. This opens our question and answer period. Again, we will take any questions from the virtual audience. Just drop those in the Q&A feature. Does look like we have one question ready. You mentioned there are risks with polysubstance use for medical reasons, which is probably due in part to age-related medical conditions. What new risks are layered onto patients when they use multiple drugs medically, but also engage in non-medical use for some or all of those drugs?
Great question. I'm trying to think of being succinct here. There's a lot of new research coming out. A lot of the work I've done recently is with gabapentin, and there has been recent studies showing increased risk of certain things relevant to those 55 and older, such as falls or cognitive issues, dementia. There was a recent paper that showed an increased risk of dementia with gabapentin. There's a paper also showing increased risk of suicidality with gabapentin and opioids. I think we're just now starting to understand what these are. The literature is coming out slowly but surely. Several papers came out this past year at the medical use of benzo, and these are all just prescribed. These are not non-medical use. These are all prescribed gabapentin. And so gabapentin and benzodiazepines, that's starting to come up of being dizzy, again, with falls. And then again, the multimodal pain research field has done a lot with meta-analyses lately, with respiratory depression in particular, of co-occurring prescriptions of gabapentin and opioids. So I think we're just starting to understand what those potential adverse events are when used medically. And I think when we take into account non-medical use, it sort of opens it up even more because we don't quite understand dosage levels or what other polysubstance use drugs are being used in the mix with those as well. So I think that's why we need to better define polysubstance use, because there's a difference between saying past month use versus use at the same time. So I think moving forward, we need to be better about what are those time frames and what are those overlapping effects.
Thank you, Dr. Ellis.